This conference will now be recorded.
Hello everyone, I am Dr. Juma Vishwas. I am going to discuss antenatal care. It's recently been published on 19 August 2021. A few things changed over here. So I just want to discuss these few things in my today's discussion. So here you can know that antenatal care is a little bit different in the UK in comparison to the other like other countries. So when a patient become pregnant and they actually gonna set in a protocol, few things we do in every cases, like in her booking, we do the risk assessment for 4 factors. One is the diabetes, one is the hypertension, one is SGA, and one is the VTA. So if any patient have this type of risk, or if any other risk related to her pregnancy, like any medical disease or any kind of like factor that can affect her pregnancy, she's gonna be in a high risk. In high risk cases, they actually need to be seen by the consultant, or if they do not have any kind of risk, they're gonna be seen by the midwives. Okay, but if any of them have an intermediate risk, in that case, their care actually shared between the midwife as well as with the consultant. Okay, that means few care will be done by the midwife, few care will be done by the consultant. So here we can see regarding the antenatal appointment. So any woman who become pregnant, their first antenatal booking appointment should be with the midwife, and that should be taken between 10 weeks of pregnancy. Okay, but if any woman delayed, like if their appointment is later than 9 weeks of pregnancy, they need an appointment with the consultant within 2 weeks if possible. Okay, because in the later dates, like if any woman a late booker, in that case you have to ask her what might be the reason of the late booker, because that can be social, psychological, or any kind of medical issue, so you need to be addressed. So that's the main important thing. So the first antenatal booking appointment should be with the midwife, and that should be with the 10 weeks of pregnancy. Okay, and overall antenatal appointment either by the midwife or the doctor. In case of nulliparous woman, that will be 10, and in case of parous woman, that will be 7. Okay, because the parous woman is at the less risk, so they can come for a few appointments, like for the 7, but the nulliparous need to be seen at least 10 times. Okay, and like there are some complex social factors also related, you have to be notified, like if any woman who misuse the substances, or any recent migrant, asylum seeker, or the refugee, and who have the difficulty in reading or speaking language, any woman below 20 years of age, or any woman who experienced the domestic violence, and according to the protocol you have to manage. Okay, so and also in her care, we always involve our partner, and it's very necessary to involve the partner, because if anything can happen, and they're gonna discuss with each other, and partner is also aware that what the situations of her pregnancy. So that's very important. So you need to be informed. And regarding the first booking appointment, we always take the detailed history, like her any kind of, so that we can evaluate whether she's having any kind of risk related to the pregnancy, like any medical history, any obstetric history, any family history, any kind of mental health issues over there, any recent medicine she's taking, because some drugs are like contraindicated in the pregnancy, so we need to be evaluate any allergy, her occupation, because some occupation sometimes can cause the risk, any family situation, whether she have adequate support, whether any kind of problem, because you can rule out the domestic violence, and like how many babies she have, and whether she have any kind of adequate support in to take care of her baby, and the contact details, so that if anything can happen, you can contact to her, and you can also need to take the contact details of the partner as well. And you can also discuss with her about the nutrition, diets, and her physical activity, smoking, alcohol intake, or whether she have any kind of taking any recreational drug. And in 2020, Embrace UK reports that maternal and the perinatal mortality, like in a white woman, is lesser in comparison with the black and mixed ethnic, and also in the Asian woman. So if you can see, in the black woman, it's like 34 per 1 lakh, but if you see, and white woman, it's less, 8 per 1 lakh, so it's lesser, so it's almost 4 times higher. And in 3 times higher with a mixed ethnic background, that is about 25 per 1 lakh. And in the Asian woman, it's 2 times higher in 15 per 1 lakh. So you can see that in the Asian black woman and mixed ethnic background, they have the high risk of maternal and the perinatal mortality. And if you can see the rate of stillbirth, in the white woman, it's only about 30 per 10,000, but it's twice in the black babies, like 74 per 10,000. But in the Asian, it's almost about 50%, like 53 per 10,000. So it's quite high in Asian and the black woman. And it shows that the women who are living in the most deprived area, they have the 2.5 times more likely to have the maternal mortality and also the stillbirth rate. So that means if you see this Asian or ethnic background, like the black people, you have to evaluate, you have to see the risk carefully. Okay, and if any woman or her partner are smoker or has stopped smoking in the past 2 weeks, you need to refer the case to the NHS Stop Smoking Support Group. Okay, so these are the few important things you have to check. And in every antenatal appointment, you have to assess the risk. You have to check her general health and well-being, and whether she have any kind of concern. You can look on that. You can manage according to that. So these are the things you have to check in every antenatal visit. And in first booking visit, you have to measure the height and weight of the woman so that you can calculate the BMI, because you know that the obese women have the higher risk of some like clinical condition like diabetes, high blood pressure, and also even the VTE. So that's why you have to check the BMI, and you also check the full blood count, blood group, and also SSD status. And in the first antenatal visit, we can also offer them to do infection screening, that is for the HIV, syphilis, and hepatitis B. And we can also offer them to do a sickle cell and thalassemia screening, because some are the carrier that they don't know that whether they are carrying this risk. So we can also check that, and we can also offer them to do the fetal anomaly scan. Okay, and if the woman is more than 40 years, not actually the 40, more than 35 years, any have a previous malformed baby, in that case, or the diabetes, in that case also we can offer them to do a down screening test between 11 to 13 weeks. And their first ultrasound scan should be done between 11 plus 2 weeks to 14 plus 1 weeks, so that we can determine the gestational age. We can also detect the multiple pregnancy. Okay, and between 18 to 20 plus 6 weeks, we can offer them further scan for screening of any kind of anomaly, and so that we can also determine the placental location. So it's not only for the baby, also it's important to see the placental location. And her antenatal appointment at 28 weeks. So the thing is that we do a booking blood test, and again at 28 weeks, we need to do the further blood test to check the full blood count and blood group and antibodies. And we also need to give them anti-D prophylaxis in case of rhesus negative women, if they are not sensitized. And few risks we need to assess, and according to we have to manage, like whether they have any kind of thromboembolism. We have to assess whether they have any diabetic risk. So if they have the risk, then we need to do a test between 24 to 28 weeks of gestation. But it's also important, if any woman who have a previous gestational diabetes mellitus, you need to check the blood sugar at booking as well as in 24 to 28 weeks. We need to assess her risk of hypertension, and if there are risks, then we can also add the aspirin. We're going to manage the case according to that. And if any time the woman below 20 weeks, if they have the hypertension, so their management like the same with the chronic hypertension, over 20 weeks, any blood pressure like 140/90 or more, they need to be reviewed in a secondary care. That means in the hospital within 24 hours. But any rise of severe hypertension, like if the rise of blood pressure 160 to 110 millimeter of mercury or higher within the same day, then needs to be reviewed in the secondary care. That means in the hospital. And then we need to be assessed any growth restriction. And if they have the growth restriction risk, in that case, they need to be seen in the consultant-led care so that they can do a growth scanning. Okay, and this growth restriction assessment should be done at booking and also in the second trimester. And like if they do not make, if we are not doing the growth scanning, in every cases, we need to measure the sympathiofundal height from 24 weeks onward. And it's not more frequently than every 2 weeks. That means then every 2 weeks or more than that, we can check the sympathiofundal height if they are not doing the regular growth scan. Okay, and do not routinely offer ultrasound scan after 28 weeks in case of uncomplicated pregnancy. So if it is a low risk pregnancy, there is no need for doing any further scan after 28 weeks of gestation. Okay, and you can ask the patient if they have any concern after 24 weeks of any baby's movement, they can come to the hospital for further evaluation. And in case of breech presentation, if we suspect that, in that case, we can do an ultrasound. But if it is confirmed after 36 weeks, we can give them option. We can discuss with them about the risk and benefits of each options. Like if it's a low risk, then we can do an ECV, or they can go for C-section, or they can go for a vaginal breech birth. So these are the few important things you need to be discussed. Okay, and at 36 weeks, we actually discussed with them about the mode of delivery and the time of delivery. So that's another important things. And regarding the induction of labor, nowadays it's written that 41 weeks beyond, we can offer them the induction. But after 39 weeks, we can do the sweep, because sweep can reduce the like indications for chance that can reduce the induction of labor. Patient may goes in labor spontaneously, and so that's why from 39 weeks onward we can do that, and from 41 weeks onward we can offer them to go for induction. But some high risk cases, they may need they may need early induction. So that will depend upon case to case. So this is all about the antenatal care management. So thank you everyone for listening this session. I hope you enjoyed the session, and if you have any query, you can ask in the comment box so that we can answer. Thank you.